Good afternoon, everyone. Once again, thank you for joining us for our webinar on updates on Mpox in collaboration with the Ethiopian Society of Internal Medicine. Our guest speaker today is Dr. Eyob Beyene. So before we start, I would like to say a few introductory remarks about Yetena Weg. So Yetena Weg is registered in Pennsylvania, USA as a non-profit organization, and it's run entirely by volunteer members. We currently have more than 70 active volunteer members scanning across 5 different countries and counting more. As you can see from the image on the right upper corner, this is an image showcasing our volunteers at a get together. So our projects and engagements can be seen in 4 aspects. The first is health promotion, which is done via discussion and articles concerning the health of the general public, health policy, and so as I was saying, Yetena Weg is more than a digital platform. It provides a platform where volunteers can come together and contribute to the society in a meaningful manner. So this is another slide showcasing our volunteers engaged in several of our inclusivity donation campaign and equity training projects. One of our other projects is the Yetena Weg Roha Health Article Writing Competition, which is done in collaboration with IMSA. So the first round of Health Article Writing Competition has been announced on September 2. Roha Medical Campus, through its Roha Health Foundation, will award travel grants for 2 Health Article Writing Competition winners, whereas Yetena Weg will award pulse oximeter for the top 20 winners and Litman stethoscope for the top 3 winners. And the top 5 winners will also get internship opportunities at Roha Health and other partner institutions. So these were the promotional posters we've been using to announce the commencement of the 4th annual article writing competition. So if you are a medical student attending this webinar, you can submit your articles for the competition. So this is another slide showcasing the 2021 article writing winner and the prize for the 2022 winner. And these are the 2023 article writing winners that got the opportunity to travel abroad. So our other engagement is the Yetena Weg Roha Research Fellowship, which is in collaboration with Roha, ጥቁር አንበሳ Specialized Hospital and St. Paul Hospital Medical College. So the first round started on March 14th of 2023 in collaboration with Addis Ababa University Medical Faculty. So 3 departments, oncology, radiology, and internal medicine were involved. Research grants were awarded for the top 4 winners. The second wing has already started and is well underway. And the other wing is done in collaboration with St. Paul Hospital Medical College, which is for medical students, mainly for interns, and research grants for the top 4 winners of the first cycle has been awarded. So these are the winners from the first competition. As you can see from this slide, there were 2 internal medicine residents, another resident from radiology and another from oncology. And these are the winners from St. Paul Hospital Medical College. Okay, so when we come to our CME sessions are freely accessible. For this, Yetena Weg partners with the Ethiopian Medical Association, with the Ethiopian Society of Cardiac Professionals, and the Ethiopian Society of Internal Medicine to provide continued training for health skilled professionals. So we invite renowned local and international speakers, and we've had 24 CME webinars so far. Our average webinar attendee ranges from 150 to 200 healthcare professionals. And for the year 2024, we've planned to hold more than 30 webinars focusing on emergency, surgical, and medical. So in order to get CEU certificates, you must fulfill the following set of criteria. The first is attend the whole session virtually. The second is fill the Google form for personal details and attendance. And the third is get 50% and above on the post-webinar quiz. So you will get your results right away, but the certificate will take 2 weeks to be delivered to your email. So we ask that you wait patiently in the meantime. So this is all about Yetena Weg. So our guest speaker today is Dr. Eyob Beyene. So Dr. Eyob Beyene is an accomplished infectious disease specialist and an assistant professor at Addis Ababa University College of Health Sciences. He received his medical degree from Jimma University School of Medicine, and he later completed his special certificate in internal medicine at Addis Ababa University, followed by subspecialty certificate training in infectious disease in 2022. Dr. Eyob has an extensive background in clinical practice and academia. He has worked as an internist in various hospitals across the country. And since 2020, he's been working at Addis Ababa University's infectious disease unit. His previous roles include lecturing at Haramaya University and serving as director of the HIV/AIDS treatment program at this hospital. In addition to his clinical work, Dr. Eyob is a certified trainer in national HIV/AIDS care and treatment and has undergone numerous trainings, including courses on clinical mentoring, emergency services, maternal and child health. So without further ado, I would like to leave the spot for Dr. Eyob. Dr. Eyob, please proceed. And thank you.
Okay, thank you. Today we will have an interesting topic for discussion. Mpox, which was previously called Monkey Pox virus. So since it's becoming a global problem, it's good to have a discussion on it. So monkeypox was first identified in 1958 when the smallpox-like lesions were seen on monkeys, but later its name changed in 2022 because humans were also affected. Now it's named Mpox. So the monkeypox is a class of the orthopox virus family. These are families, the DNA viruses like the variola virus, which causes the smallpox, the cowpox virus, and also the vaccinia virus, from which the smallpox vaccine was produced. So it's very similar. These viruses are very similar. So that's why smallpox virus vaccine protects against monkeypox. So it was an endemic disease in Africa, and also usually it's transmitted from animals to humans. But after the 2022, the things are changing, and its dynamics has changed after the year 2022. So the first monkeypox case was identified in 1970, but monkeypox, the virus was identified in 1958. And we have two classes of monkeypox virus. Formerly, they are known as the Central African or Congo Basin clade and West African clade, but currently we call them Clade 1 and Clade 2. Clade 1 is from Central Africa, and Clade 2 is from West Africa. And the Clade 1 tends to be more severe than the Clade 2 variant. And the Clade 2 is famous currently because the 2022 outbreak, which involved the Western countries, is caused by the Clade 2B variant. So Clade 1 and Clade 2 were its classes. The Clade 2 is famous currently because in 2017 there was an outbreak in Nigeria in West Africa, and because of the globalization, the Western world seized the cases, and the outbreak, the 2022 outbreak, was caused by this Clade 2 variant. Clade 2 variant, but it tends to be less severe, and sex was found to be the effective means of spread, and MSM groups, the gay community, were the most affected ones, most probably because of the mode of transmission. We will come to it later. So in general, monkeypox has prodrome to 5 days, and the incubation period is around 2 weeks. So the illness will last from 2 to 4 weeks. So initially the patients will have fever, malaise, headache, weakness, and myalgia. Then they will develop lymphadenopathy, and they will develop rash. The rash has predictable pattern. Initially it will be macule, then papule, then clear vesicle, then it will be pustule, and it crusts, and finally the crust will heal. The crust will heal. So the Clade 2B outbreak was very typical. That means initially the clade, we know mostly about the Clade 1 variant, and also the rash and the population group that are affected were different. In the Clade 2B variant, MSM groups, including patients with other STIs and also patients with HIV, were affected, and the transmission was sexual contact, and the rash was not like centripetal. Usually, monkeypox rash affects the arms, the acrum, and the face, but this variant affected the centrifugal area, abdomen, pelvis, and mostly in the genital area, and the mouth were affected. So and also there were few prodromes, and severe, it was not that severe, though severe disease were seen in people who have advanced HIV and other immunosuppressive conditions. So the Clade 2 outbreak were typical. So these are the rashes due to Clade 2B. As you can see, the genitalia, the mouth, centripetal areas were involved. And this is not what's known initially about the Mpox virus. So in general, Clade 1 or Clade 2 variants, they will cause severe disease in people who have underlying medical conditions like inadequately treated HIV or advanced HIV, other immunosuppressive conditions like organ transplantation, and patients on immunomodulatory or immunosuppressive therapy, and patients who have primary immunodeficiency might be affected. And also patients who have underlying dermatology conditions might develop severe forms of the disease. So both clades are similar. That means they will have typical rashes, and transmission is like contact with the lesions, fomites, and respiratory secretions, especially through intimate contacts, and also surfaces which are affected or which are contaminated by large respiratory droplets might be a cause for the transmission. So diagnosis is similar, and the protection equipment, the vaccine, and the other measures will be similar, but Clade 1 is different from Clade 2. So Clade 1 may not affect predominantly the MSM group, and Clade 1 associated with more viral shedding and severe disease than the Clade 1. So Clade 1 tests are not commonly available because it is usually because the Western world doesn't see it. It's because of resources. So, but both Clade 1B and Clade 2B might be a problem in Africa or Ethiopia, but Clade 1B is the immediate danger because it is disseminating in Eastern Africa, and we are seeing more cases and more diseases because of Clade 1B variant, but still Clade 2B might cause a problem. So we have seen a surge of cases in Democratic Republic of Congo because of Clade 1B variant, and there was 4 diseases, 371 hospitalization in a year, and also pregnant and children, they were mostly affected by this Clade 1B variant. So the Clade 1B variant propagating in Africa, and it can be a global concern. And unlike the Clade 2B, heterosexual transmission is seen in the Clade 1B variant, most probably because of the contact and other STIs, and the commercial sex workers were more commonly affected. So the median age was 21 years. Females are more affected than males, and crossing the borders is a possibility. And our country, since it resides in the East Africa, there is a high chance of becoming an epidemic in our country too. So it has high transmission, and children are affected, and the mortality is high in children. So Clade 1B cases might affect Ethiopia. So like if it affects Ethiopia, most likely it will be imported cases, and the diagnosis might be delayed because a lot of diseases mimic this monkeypox, and since it might be picked late, we have to have a close like follow-up. Requires close sustained contact for transmission, but we have to be also vigilant to pick it early. And like the other Clade 1b cases that occur in other parts of the world, heterosexual transmission plays the most important role. And most likely it will be severe in children, immunosuppressive who are on immunosuppressive medications and immunosuppressive illnesses. So it is a possibility, and we have to be vigilant of it. So this is a picture that I have got from Tikva magazine today. So the monkeypox is becoming like rampant in the Burundi, and it has affected more than 20,000 people, and also children were the most severely affected ones. So we are in East Africa. We have to be vigilant of the monkeypox, both Clade 1b and Clade 2b variants, specifically Clade 1b variant. But since there is globalization, outbreaks because of Clade 2b or Clade 1b is a possibility, but Clade 1b is the more serious one, and also we're in East Africa, and we expect outbreaks because of Clade 1b variant, Clade 1b variant. So in generally, monkeypox, Mpox is a benign disease, but there are complications. The most important complications are superinfections of these, the rashes, the ulcers. So superinfection because of bacteria and sepsis might be the most important complications, but there are other complications like ophthalmologic complications, conjunctivitis, corneal ulcers, scars, and neurologic complications are also a possibility. Myocarditis, pericarditis, and also acute arthritis are also important complications of this, the Mpox virus. So severe complications because of lymphadenopathies might be there. Ulcer-related strictures, severe lymphadenopathy causing obstructions in different sites of the body. And as I've told you, sepsis from the wound or the skin infection is a possibility. So severe complications might occur because of the Mpox. So the transmission is initially it was from animal to animal and also animal to human, but now there is a sustained human to human transmission because of direct physical contact with infectious skin rash and also sexual transmission because of contact. So, and also touching heavily soiled items like clothing, this might be there. And also from mother to fetus transmission is a possibility. Large respiratory droplets might be a cause, like they can contaminate surfaces, and also they can be sources for transmission, but aerosol transmission is not that much common, and there is no clear like guide or evidence about aerosol transmission. But in general, respiratory droplets might lie into surfaces, and they can be source of transmission. And also like intimate contacts might make respiratory droplets to cause the disease. So the most important is the contact transmission, direct contact transmission. So patients can be infectious even before the rash. So 4 days before the symptoms onset, patients can be symptomatic. So mucosal transmission is possible even before the rash. So that's why heterosexual transmission and also MSM groups MSMs might acquire the disease, and also it's not advised to rub or to dry off this soiled sheets, bed sheets, and they can be source of transmission. So the risk of transmission in brief contact is very low, even though there are reports of healthcare workers which acquired the disease in Africa, 3 healthcare workers during the recent outbreak. So how often Mpox is spread via respiratory secretion is not known, but it's a possibility. Large droplets might land into surfaces, and also from the hospitals, ceilings, and also corners of the hospital where humans cannot reach, the virus has been isolated. So large droplets might play a role in transmitting the monkeypox, but respiratory route is not the most common way of Mpox transmission. So animal to human, humans to human, human to human transmission is possible, but the current outbreak is increasing because of sustained human to human transmission, which is not the case during the initial endemic monkeypox cases that we know in the past. So direct contact with infectious rash, scabs, or body fluids, secretions, face-to-face contact, or intimate physical contact might cause transmission, and indirect contact with the lesion material such as clothing or linen, and also mother to child transmission of the virus is possible. So how do you examine and diagnose Monkeypox? So we have to collect samples from the skin in mucosal examination, and the most important sites are the skin lesions. And we have to take thorough history, especially within the past 3 weeks. Travel history and sexual history should be asked, and we have also to consider different differential diagnoses that can mimic Mpox, like syphilis rashes, varicella, molluscum contagiosum, and bacterial infections might mimic Mpox. And also other STIs are common in patients with Mpox, so STI screening should be done, and also the health department should be alarmed. I take this slide from the CDC guideline. So the clinic presentation is fever, chills, headache, malaise, myalgia, then lymphadenopathy, and as I have told you, the rash will be macules, and it will be papular, then it will be clear vesicle, then pustule, and it will crust and dry off within 4 weeks. And the person can transmit the infection from 4 or 5 days before the rash appears to the rash, the healing time of the rash. Until the rash heals, the patient is still infectious. He's still infectious. So how do you testing is done from the lesions? PCR tests are the most important tests that are done, but rapid tests are also coming to the picture. But high clinical suspicion is very important for diagnosing Mpox, So as an infectious cause of rash should be considered, especially drug rashes, syphilis rashes. It can involve the whole body, including the palms and soles, disseminated varicella. There are lists of differential diagnoses. Clinicians should be aware that patients might have a concurrent infection too. So the management is usually mild, and most of the cases will be mild and self-limiting. So without specific therapy, the patients will recover. And pain management, skin care, wound care are very important for the Mpox treatment, and also stratifying patients who might develop severe disease is very important. Children, immunosuppressed, patients with immunosuppression, patients who are taking immunosuppressive medications should be stratified, and some patients might require antiviral therapies. So these are the antivirals which are tried during the 2022 outbreak. Tecovirimat is one antiviral. It has shown efficacy for Mpox treatment. So in severe cases, it can be used, but for post-exposure prophylaxis, it's not studied yet. But in severe case of Mpox, it has been used in the recent outbreak, and it is efficacious. So it's available under the research program, and it's an oral capsule. So still in severe cases, this antiviral might help, but it might not be available in our country unless we are part of some research project. So patients with underlying immunocompromisation can need further care, like the ulcers might be infected, they might develop abscess, it might need debridement, and also treatment for the super infection. So on top of managing the Mpox, optimizing the immune function should be the most important thing to do. Like the COVID outbreak, our immunity plays an important role. So ensuring optimizing the immune system is very important. Like if the patient is not on HIV treatment, putting on HIV treatment, and also if the patient is on immunosuppressive therapy, decreasing immunosuppressive therapies or changing them, or if the clinical condition allows, like stopping them for a brief time might be needed. So optimizing the immune function should be also one of the important jobs of the treating physician. So the vaccines are available. The Jynneos vaccine and this the ESIM 2000 vaccine, the previous vaccine for Mpox. The previous vaccine, it needs taking, like it's the live vaccine, and there is serious adverse events might be there, and also immunologic response like the take is required. Multiple punctures to a single dose is administered. People who are vaccinated for smallpox might know it, but there is a better vaccine, Jynneos vaccine, and it's replication deficient, and that makes it more safe, and also take after the vaccination is not required. The take is at the site of the vaccination, there will be inflammation, healing, and we call that take but this Yetena vaccine will not require take, and fewer adverse effects are expected. And it's safer than the ESIM 2000 vaccine, and 2 doses of subcutaneous administration 4 weeks apart is required. And this is the safer one, and we expect this Yetena vaccine to be administered to areas which are affected. So it's live attenuated vaccine, and FDA has licensed it in 2019, and 2 doses are administered 28 days apart, and it can be used before potential exposure, or it can be used also as post-exposure prophylaxis. So it is efficacious and safe to use in those who are immunocompromised, and it has demonstrated to be safe in the current outbreak. So safety is not established in pregnant person, breastfeeding mothers, and also children. So it's contraindicated in patients who has prior allergies to egg, and also gentamicin and ciprofloxacin. Fragments of gentamicin and ciprofloxacin are there in the vaccine. So if the patient has egg allergy or allergy to gentamicin and ciprofloxacin, we have to be cautious in administrating this vaccine. So it should be in patients who have egg allergy, it shouldn't be given, and it's efficacious. Especially the 2 doses are very efficacious, the 2 doses of the vaccine. So if you give the 2 doses, like, it can be as effective as from 66% to 89%. The single dose, for a single dose, the efficacy might drop as low as 36%, but if we administer 2 doses, the efficacy can be as high as 89%. So it's efficacious if it's administered in 2 doses. So this is the Yetena vaccine. And vaccine post-exposure prophylaxis also should be given, even though there is no post-exposure antiviral. Vaccination should be given even as a post-exposure prophylaxis. So these are the things that I want to say about the current monkeypox outbreak. I was running fast to cover it in time and to have time for discussion. So if there is any question, I will entertain.
Thank you very much, Dr. Eyob. So you've provided a concise and thorough explanation for the current outbreak and the management strategies in an interesting and engaging manner. So for that, I would like to say thank you. So we have some questions in the Q&A. My co-host, Dr. Srafil, will share his screen and we can go over them. Okay, so the first question reads, was there any reported case of Mpox in our country?
So there is no reported case of Mpox in our country till now.
Okay, thank you. The second question reads, how is the government preparing for this devastating disease?
So I might not be the right person to answer this question, but I have seen like prompt responses from the government in Addis. When you suspect like Mpox cases, they do rapid assessment, and also rapid diagnostic tests are also there. So I have witnessed. I can be a witness for one case. We suspected Mpox, and the response was rapid. They tested the patient, and Mpox was not there. And also, finally, the patient was found to have a drug allergy, Stevenson-Johnson syndrome. Finally, it turned out to be TEN.
Okay, thank you very much. The third question reads, what is the effect of monkeypox at all stages of pregnancy?
So it can cause stillbirths, abortion. Stillbirths and abortion are the most commonly seen complications. But since the cases are now surging, we will know a lot in the near future, but still there's more fatal intrauterine fetal deaths and also abortion are commonly seen. But we will learn a lot in the future because we are seeing loss of kids now, and the outbreak is starting. And the 2022 outbreak is in the MSM group, so it was not in the heterosexual population. So we will see. We might see. We'll learn a lot in the future.
Okay, thank you. The fourth question reads, can monkeypox skin rash heal fully without scarring?
I don't think so. So definitely it will leave a scar. It will leave a scar.
Okay, thank you. The fifth question, how does the drug work for the treatment of Mpox? What is its pathophysiology?
So we know very little about monkeypox, Mpox now. So the knowledge about Mpox will accumulate in the future. The example is COVID. During the initial outbreaks of the COVID, a little was known about COVID, but with time, a lot of information, a lot of science accumulated, and we know now a lot about COVID. That's the same for monkeypox. There are a lot of questions that needs to be answered, including the pathophysiology of some of the drugs, like post-Mpox sequelae. So there are a lot of questions that will be answered in the future. But currently, our understanding is limited.
Okay, thank you very much. So the next question reads, it said as part of the treatment, boosting immunity is one of the options. So is it recommended to give vitamin C or D or zinc supplements?
No, it's not clearly indicated by the CDC and other guidelines, but giving it might not do harm. But usually patients who are immunosuppressed, severely immunosuppressed, pregnant women and children are affected. And giving supplements might not cause any harm, but there is no clear evidence of supplying this vitamin D, zinc, for this Mpox. So there is no clear guide by the CDC and other organizations.
Okay, thank you. So the seventh question reads, is there a chance of transmission from mother to child during pregnancy?
That was answered during the presentation.
Okay, thank you. The next question is breastfeeding contraindicated in mothers that are infected with Mpox?
If the child is not definitely it will be a problem. Virus also resides in the skin, so the mother will have definitely rash. So the close contact and also the skin to skin interaction might make the infection to the newborn possible. So breastfeeding will be a problem, especially during the rash.
Okay, thank you. The ninth question reads, who will we contact if we suspect an Mpox case?
So like the cases with COVID, cholera, the Mpox, as also in the Ministry of the Health, there are contact persons to contact. It will be different from cities to cities, but in the Ministry of the Health, there is separate group that are responsible for these cases. So especially when the time comes, there will be it will be posted and it will be known. But in the Ministry of Health, there is a separate group.
Okay, thank you. The 10th question reads, how do we isolate an Mpox patient?
So it's not airborne. Contact precaution is what is needed. contact precaution is what is needed. So like universal precaution will be enough, and we shouldn't panic. It's not a virus that's easily transmitted. Like it will not be transmitted with like brief contact. It will not be transmitted with a brief contact if someone sits besides us. So it's not like COVID. So contact precaution, universal precaution should be enough, and also especially surfaces should be cleaned thoroughly, and the universal universal precautions will be enough.
Okay, thank you. The 11th question reads, what are the available diagnostic modalities in our setup?
So in general, in the world, the PCR tests are the most widely used, but there is rapid diagnostic test and in our country too. So PCR is mostly utilized in general in the world, and we will see. Since still there is no case in our country, we will see what we can do. But PCR test is the most importantly used test in general in the world, and also rapid diagnostic tests are coming to the picture. But PCR dominates.
Okay, thank you. The 12th question reads, is the vaccine dose similar for post-exposure prophylaxis, specifically the interval, and how is its efficacy?
The vaccine is similar. Like we have to administer 4 weeks apart. The dose is also similar. The efficacy, I didn't see any study. So we are, as I have said, we are learning a lot about Mpox. So there is a scarcity of data, and the nations that face the outbreaks are the ones who generate the data. So there is no study done to check for the efficacy of post-exposure prophylaxis. But 2 doses of vaccine, the vaccine will be as effective as 66 to 89%.
Okay, thank you. The 13th question reads, for how long should a patient abstain from unprotected sex after recovery?
It's not like the other viruses, like for example, in the viral hemorrhagic fevers, someone has to abstain for more than 3-4 months. Here, the disease can occur during the prodrome before the rash occurs, and also after it is till the rash heals and scars, the person is infectious. So like we have to, in general, we have to advocate safe sex. Condoms might not prevent Mpox because there will be contact with the skin and the lesions, and also, as I've told you, even during the prodromes, the virus can be transmitted. So advises, it's commonly seen now, even in Africa, it's seen in commercial sex workers, and also in Western, the MSM groups. So the contact is very important risk factor, the contact. So like prolonged abstinence is not in the ties, but like the commercial sex workers, and also.
Okay, thank you very much. So the next question reads, how accessible is the vaccine?
Funds being raised, is being raised, and also we are in the mercy of the Western countries. Hopefully, it will be accessible. So donations, a lot of funds are being raised by the WHO, and also the WHO has declared it as a global emergency. So the funds are being raised, and the vaccine will be accessible, but it's not in our hands.
Okay, thank you. The 15th question reads, what is the commonest cause of death in a patient with an Mpox infection?
So superinfection, the commonest cause is especially sepsis of the wound focus. Superinfection of the ulcerated wounds is the commonest cause.
Okay, thank you. The 16th question reads, what are the definitions for suspect and confirm case definitions?
Okay, there are a lot of questions, and a lot of questions are coming to the picture. So there will be a case definition for a suspect and a confirmed case of Mpox, but logically the confirmed case is someone who has positive rapid test or PCR test. Suspect is someone who has typical history and also rash, which resembles Mpox.
Okay, thank you. The 17th question is how much is the mortality with the Mpox?
So the mortality is different for clade 1B, clade 1 and clade 2. So we should expect both, but clade 1B is most likely to enter Ethiopia first, but the mortality is higher for clade 1B. It can reach as high as 4%. But for clade 2B, it's less than 1%, and the mortality is very low.
Okay, thank you. The 18th question is how may we differentiate case of Mpox from other differentials other than the rash, and what can be done in our setup for cases that are immunocompromised if we can't get our hands on the tecovirimat?
So if there is a strong suspicion of Mpox, and also if the person has travel history, especially, you should communicate the ministry, and rapid tests, PCR tests should be done, and also tests for diagnosing the thorough history and tests to diagnose the other differential diagnosis should be done. But if there is travel history and if the rash is typical, so the clade 1B type rash or clade 2B type rash, like the diagnostic tests should be done, and also we should alert local health authorities.
Okay, thank you. The 19th question reads, are there any domestic or international guidelines available to be shared?
So the CDC has released a guideline, and also there are also courses you can take from the CDC. The only source that has a guideline and also courses is CDC.
Okay, thank you. The 20th question reads, is lymphadenopathy a prodromal phase sign?
Yes, and it will continue during the disease usually.
Okay, thank you. So the last question reads, is cidofovir used for Mpox?
Yes, it's used, but I didn't find researches for its efficacy. That's why I omitted it. Cidofovir also is used, and also it's used for smallpox in the past.
Okay, thank you very much, Dr. Eyob. So you've managed to address all of the questions in a patient manner. So having said that, we'll directly proceed to the Q&A. Okay, so the first question reads, what is the most common mode of spread of Mpox during the 2022 to 2023 global Mpox outbreak? The first choice is sexual contact, B is contact with infected animals, C is infection in healthcare setting, and D is household contact.
So most of the attendees answered it correctly. It is a sexual contact.
Okay, thank you. The second question reads, laboratory confirmation of Mpox is best done with specimen taken from which of the following? A is blood, B is urine, C is lesion on skin or mucosa, and D is a throat swab.
So the lesions from the skin in the mucosa yield the most.
Okay, thank you. The third question reads, those who may be at higher risk of severe Mpox and medical complications include the following except A is children, B is pregnant women, C is persons living with well-controlled HIV infection, and D is immunocompromised patients.
So persons with living with well-controlled HIV infection, they are not at increased risk. That's the same with the COVID outbreak. So we should treat them like the other population group also in treating them.
Thank
They are
you.
not at increased risk.
Thank you. The last question reads, which of the following vaccines is currently approved for use in the prevention of Mpox? A is the MMR vaccine, B, BCG vaccine, C, Joannos vaccine, and D, influenza vaccine.
Rhogeoinus vaccine is the approved one for Mpox treatment.
Okay, so on behalf of Yetena Weg and everyone that has attended, I would like to extend our heartfelt gratitude to Dr. Eyob for your insightful presentation. So your expertise and thorough explanation of the current outbreak and the management strategies were invaluable, and we truly appreciate the time and effort you've dedicated to making this webinar a success. So I would like to say thank you, and to everyone that has attended, I would like to say thank you as well.
Thank you, everyone. Also, the attendees and the Yetena Weg attendees, they have sacrificed their weekend to stay with us. Thank you, Yetena Weg, and also the attendees.
Okay, thank you, everyone, and good night.